Well, hello, everyone, and welcome to our case conference webinar series via the Academy of Consultation-Liaison Psychiatry. I'm Dr. David Fipps. I'm a CL and addiction psychiatrist at Mayo Clinic, and I'll be moderating the event and introducing our speakers. And as a reminder, this event is one of many in a monthly series of alternating case conferences and educational webinars, so be on the lookout for upcoming events. But today's 30 to 45-minute case conference representing the addiction and the toxicology SIG will include a brief case presentation by a trainee, followed by a facilitated case discussion with a CL faculty member, and then end in a Q&A session. So if you have questions, please put them into the Q&A option. Feel free to use the chat for comments, but we are only going to be answering questions that are inputted into that Q&A option. So our trainee presenter today is Dr. Michael T. He is a PGY3 psychiatry resident at Baylor College of Medicine. And our faculty discussant today is Dr. Blair Walker. She's a clinical associate professor of psychiatry at the University of Texas at Austin Dell Medical School. And without further ado, I'm going to hand it off to Dr. T for his presentation.
Thanks so much, Dr. Fipps. Excited to be here with Dr. Walker, whom I know from my med school days back in Austin. Special thank you to Dr. Fipps and the rest of the ACLP crew for putting this together. And a special thank you to Dr. Ben Ummer, the attending whom I saw this patient with and provided some mentorship that allowed me to present to you guys today. So our case begins with a 27-year-old man with unknown past psychiatric and medical history. He was brought in by police to the emergency department for wandering the streets and banging his head on cars after a recent release from jail. He was combative in the emergency department and had to receive emergent medications intramuscularly. That hardly touched him, and he required further medication by ketamine infusion, which calmed him down for about an hour. During that time, our emergency medicine colleagues were able to do further workup and found him to be profoundly hypotensive. He had scattered bruising on his face, chest, and arms, and he had abnormal responses both verbally and in terms of his motor responses. In his blood work, he was pancytopenic with a low hemoglobin. His urine drug screen was positive for cannabis and benzodiazepines, although he was recently emergently medicated with benzos. And his head imaging was without any acute findings. So given his hypotension and his pancytopenia, he was transfused with a unit of packed red blood cells and fresh frozen plasma, which improved his blood pressure as well as his Glasgow coma scale. However, unfortunately, he became again combative. He was lunging at staff and required 4-point restraints. He was admitted to medicine, and psychiatry was consulted for bizarre behavior. So what to do with this patient who's encephalopathic, physically agitated? Well, when we first saw him, he was still in 4-point restraints, and his chief complaint was that his legs hurt. He was agitated, confused. He thought the year was 2027, and mind you, this was in late 2025. Throughout our interview, he was very guarded. He did endorse heavy drinking, which he stopped a few days ago, but he was unable to specify the exact amount. He answered yes to trauma, but declined to elaborate further. And towards the end of the interview, he cryptically said, "They're all dead," and then clarified that he was referring to his parents. He then became very agitated and started to cuss out the team, so we left the room. Fortunately, we were able to get some records from the jail where he had reported nearly daily nitrous oxide use. During his jail intake, it seemed like a routine intake. He was his normal self, but over the course of about 6 hours, he became disoriented and combative with another peer who he mistook as a celebrity rapper. He was released from jail custody the next day and started to hit his head on cars, which is what brought him to the emergency room. Further chart review showed that he had a history of major depressive disorder, as well as various substance use disorders, including alcohol, cocaine, cannabis, LSD, and inhalants. He had one prior psychiatric hospitalization for suicidality and aggression, and here were some of the precipitating factors that were happening at that time, including the loss of his father, caring for a sickly mother, facing financial stressors, increasing substance use, the purchase of a firearm, and the assault of a police officer. At that time, he was medication naive and was started on a regimen to help with his depression as well as sleep. So fluoxetine 10, quetiapine 100, and trazodone 100. He was seen outpatient for about 4 months, but was eventually lost to follow-up. Regarding his family psychiatric history, he has a mother with substance use disorder, as well as a maternal uncle with either schizophrenia or bipolar disorder. His own personal past medical history included non-convulsive epilepsy, as well as ulcerative colitis. And again, his father had passed away due to COVID. His mother was also recently deceased due to unknown causes. And since her passing, he's been living with a roommate. He's well educated with a bachelor's in engineering, as well as various certifications in psychology and business. He was unemployed, relying on his trust fund for his expenses, and also doing some day trading. Uh, his substance use, we've already briefly touched on, and it included nitrous oxide. So, what did his mental status exam look like during our encounter? Well, he was disheveled, guarded. He had his 4-point restraints. He was confused about the year. He had increased response latency. He kind of vacillated between being inattentive to anxious to irritable, and overall, he had limited insight and judgment. We touched a little bit on his blood work, so this was kind of the repeat blood work that happened. Initially, there was concern for acute kidney injury given an elevated BUN, but that resolved. His leukopenia actually got worse before it got better, probably due to some sort of dilutional aspect given his transfusions. The transfusions did help with his hemoglobin as well as his platelet count. His TSH, his urinalysis, his blood alcohol level, and lumbar puncture were all within normal limits. He did have a UDS that was positive for cannabis and benzos, and his B12 was notably undetectable. So further workup, including CT and MRI of his head, has showed no acute abnormalities. EEG, when we were eventually able to do it, showed no seizure activity, but did show diffuse slowing, indicative of delirium. So in summary, we have a 27-year-old man who presented with physical agitation. He was found to be disoriented, pancytopenic, had an undetectable vitamin B12 level. His UDS was positive for cannabis as well as benzos, although he was emergently medicated, and his EEG showed diffuse slowing. So what can be going on here? Well, the leading differential would be a severe vitamin B12 deficiency given his reported nitrous oxide use, his pancytopenia, and his agitation and encephalopathy. Admittedly, we had a very limited neurological exam, but there didn't seem to be any concerns for paresthesias or ataxia. Could there have been a TBI, given that he was assaulted in jail and was hitting his head on motor vehicles before his presentation? Well, normal head imaging kind of argues against that. Could he have been using synthetic cannabis, which may or may not show up on routine urine drug screens? And could this be some sort of psychosis induced by cannabis use? Well, he was hypotensive rather than hypertensive, and he didn't have any GI upset. And could this be some sort of sequelae, either from alcohol intoxication or withdrawal? Again, no alcohol was detected on his urine drug screen or his blood alcohol level. And so before I hand it over to Dr. Walker to lead us through a discussion about nitrous oxide use disorder, here are a few questions to kind of guide the discussion. What should we look out for in nitrous oxide use disorder? What's the pathophysiology behind it? What workup is indicated? And are there any other considerations for the treatment of chronic nitrous oxide use? And with that, I'll hand it over to Dr. Walker.
Thanks, Dr. T. Sorry about that. Thank you for having me. That's a great case presentation and a really interesting case. And unfortunately, I'm also seeing a lot more commonly people presenting with problems associated with nitrous oxide use. So what the heck is it? If you've never heard of whippets before, nitrous oxide is a colorless, non-irritating gas. And historically, it was used in whipped cream dispensers. And so hence the name whippets. It's laughing gas. It's also used as an anesthetic agent in dentistry, in OB, and also in emergency medicine historically. And why is it used that way? It's an NMDA receptor inhibitor, and it also acts on the endogenous opioid system and produces rapid onset euphoria, dissociation, and analgesia. It's very short acting. It's really seconds to minutes. It's not a long time, but it does give quite a high, hence people using it recreationally. And what we're seeing epidemiologically is that over 13 million people in the US have used it at some point, and that the poison control centers from 2003 to 2024 have seen a 1,300% increase in calls about basically poisoning associated with nitrous oxide. So it seems like what we're seeing anecdotally in our clinical practice is in the literature, it's becoming a more commonly used and available substance. And how does it work? Why does it cause problems? So if you think of nothing else that associated with nitrous oxide use disorder, think about B12 deficiency. You don't ever want to miss this. It becomes a permanent sequelae from chronic use of nitrous oxide. What it does is it basically functionally renders B12 not work in the body. So it oxidizes the cobalt in B12 irreversibly. So even if you have normal B12 levels in your system, and it was lucky in this case that the B12 was undetectable, but even with normal B12 levels, you can have essentially a B12 deficiency and have very serious sequelae from that. And what do we see with B12 deficiency? We see kind of the typical neurological triad: polyneuropathy, myelopathy, encephalopathy. So we see things like paresthesias, ataxia, gait instability, all coming from basically a subacute combined degeneration of the spinal cord. You can see megaloblastic anemia. You can see paralysis. And also a notable thing to remember about nitrous oxide use and B12 deficiency is that people are more prone to clotting. So thromboembolus is a possible sequelae. It's rare, but it's possible and something to think about. Those are all chronic risks of using kind of over time. And then there's acute risks of inhaling nitrous oxide, frostbite from direct inhalation, asphyxia. You can develop a pneumothorax, you can have seizures, and there are some rare incidences of death associated with acute use of nitrous oxide. The biggest thing to think about, though, is B12 deficiency. You want to do a thorough workup. And like I said, the B12 level is not the only thing. So you always want to be testing homocysteine and MMA whenever you're working anyone up for a concern for B12 deficiency, but especially in the case of nitrous oxide. And you don't want to wait for the results. So a lot of times our labs is a send out. It takes a while to come back. Get them on B12 supplementation immediately, ideally at least intramuscularly. And then they need to be on the appropriate treatment once you have the results back, and you just replete until you've either proven they don't have a deficiency or follow the algorithm for the deficiency that you find on the proper workup. The other kind of takeaway is just whenever you're thinking about or evaluating adolescents and young adults especially, don't forget to ask about nitrous oxide and inhalant use. It's more common in the young, and these days with social media and the availability of online ordering, there is a lot of marketing to youth. There are like specific nitrous companies. There's one called Galaxy Gas and things like that are specifically not, it's unregulated, and there's no health warnings, and younger adults are ordering this stuff online or picking it up at head shops, and it's becoming more common. So you don't want to forget about it. I think it's important to kind of add it to your arsenal of questions when you're addressing substance use in your evaluations of patients. And the other thing is that, when people do have sequelae from, for instance, B12 deficiency, recovery is possible, but it's often not entirely like complete. So you often have long-term sequelae from this problem. Really important to make sure that you're counseling on proper supplementation, but also cessation of the nitrous oxide, because you can supplement all you want. If you keep on using nitrous, the B12 we're giving you is going to be rendered not functional anymore. So you have to sort of educate your patients and make sure they understand this, and their symptoms could get worse if they're not attending to it. And then, trying to support them otherwise. There's also a recommendation that you also replete with folic acid as well. And just realize that very commonly patients, even if they recover functionally, could have persistent paresthesias and sensory ataxia chronically. Recommending physical therapy when it's indicated and things like that are, always a part of the recovery process. And then, appropriately connecting them to the resources as far as substance use disorders go. Dr. T asked, what can we do as far as the treatment of nitrous oxide use disorder? we don't have a lot of evidence-based treatment for it. I would argue only personally that it never hurts to try things like, could a naltrexone be effective? I don't know. Try it. See if it could help someone with cravings for it. There is going to be a dopamine hit with Euphoria, and could that be effective? Maybe. But really getting them into treatment, getting them engaged in treatment, and exploring what else you can support and change in their lives that can help, decrease the risk of the substance use kind of reuse. Those are kind of my main takeaways about nitrous oxide use. So I'll hand it off back to Dr. T to give us an update on the case.
Thank you, Dr. Walker. Initially, what we had recommended were benzodiazepines to kind of prevent any alcohol withdrawal concerns, as well as valproate and diazepam to further provide some seizure prevention. However, his repeat blood work showed some transient transaminitis that later resolved, and his EEG showed no seizure activity, so we recommended discontinuing the benzodiazepines and the valproate. Simultaneously, he was also on B12 supplementation, just like you had mentioned, intramuscularly. This was followed by PO supplementation, and his encephalopathy actually improved after 48 hours. During his hospital course, as his encephalopathy improved, he did start to show signs of depression. So he was endorsing some passive intermittent suicidal ideation and was amenable to restarting his fluoxetine and trazodone. At discharge, he still continued to make odd statements about fighting this misidentified person. And unfortunately, 6 months later, he had another hospital admission for similar presentation, again showing how difficult relapse and continued substance use can be.
So we will hand it off now, I guess, to me for the Q&A session there. So excellent job, you two. That was a very interesting case, and one that certainly brings up a nice diagnostic conundrum if they're coming in and it's not obvious what they're using. And great discussion with it. Learned a lot from that, certainly. And looks like we're already getting quite a few questions in the Q&A. A lot of them kind of, or at least a few of them, kind of revolving around the concept of what we are replacing and repleting for them when it comes to, are we starting both folate in addition to IM B12, and as well as kind of this concept of the mechanism you described. Can you explain a little bit more how you can have a functional vitamin B12 deficiency with it when the B12 level is actually fine? Thus, some people may limit their B12 repletion in those cases.
Sure. Thanks for that question. It's a good one. So basically, like I said, it irreversibly oxidizes cobalt in B12, and it basically renders it ineffective. So even if you have B12 floating around and your lab is picking up on a normal B12 level, that B12 doesn't work in your body because the cobalt has been oxidized and it doesn't work right. And so essentially you have a B12 deficiency. So that's sort of the mechanism of how that works. So even if you have normal B12, you still want to be doing a thorough workup to elucidate that there is a functional B12 deficiency by checking homocysteine and MMA. Even if you have a normal B12, honestly, if I had a person who is admitting to nitrous use, I don't care what their B12 says. Like, I'm pulling the labs and sticking B12 in their body immediately because the sooner you get it repleted and on the right track, and hopefully replacing some B12 that hasn't been irreversibly oxidized, you're getting them on the path to recovery.
Excellent. Gotcha. And just in case I missed it, did we also mention we would universally use folate as well in those cases?
Not necessarily. You just want to make sure that you're checking a folic acid level as well in case they have any other deficiencies. It's part of the kind of general recommendations if you kind of do sort of a literature review. And, I sort of would think about it as if they're doing a lot of nitrous, they might be doing other things. They might not be nutrifying very well. Other vitamin deficiencies may be at play that have nothing to do with the nitrous oxide. So that's the general kind of thinking there.
Gotcha. We got a few comments and questions in here regarding how this intertwines with fertility and pregnancy, actually. One is a source of a letter to the editor regarding nitrous oxide and fertility having an increased risk of spontaneous pregnancy loss. And so that may have prompted someone else to have asked about could this cause neural tube defects, especially if the individual used nitrous oxide while pregnant.
I don't have an answer to that. That's a great question. And I could be completely wrong, but neural tube defects more often with folic acid deficiency. Nitrous oxide isn't necessarily associated with folic acid deficiency itself. It's a specific B12. But if B12 deficiency causes it, then it's a theoretical risk. I don't think huffing nitrous is going to be good for any pregnancy in general, I can say with like firm abandon.
Solid.
Yeah, I don't have a good answer to that though. I would have to do a deeper dive. And actually I can paste my email in the chat if anyone wants to like continue a thread of discovery about that.
Would be very interesting to see. And certainly that brings up a really good point about substance use in general in the pregnancy population. And as long as we're talking about B12 and replacing it, there's a good question here regarding like after their discharge from the hospital, how long would we recommend that we continue to draw B12 and following this up, and how long would we keep them on B12?
Yeah, another really good question. So the general recommendation is to continue to supplement. You're either doing weekly or monthly supplementation based on your algorithm, basically until symptoms improve or are gone. So you want to aggressively replete it, and then the question is, can you retain that person in care? It depends on how you operate. I'm a CL psychiatrist in medical hospitals. I don't get to see them in clinic, but you're trying to connect them to care so that their new care providers, hopefully substance use disorder clinic, can check in on them, see how they're doing as far as nitrous use. If they're still using, you can continue to check levels, but again, not just B12 level. You need to be checking the other lab work. And the most important thing is B12 supplementation and trying to support them in as much cessation as possible. I would argue, we always attempt harm reduction, and I would say yes, less is better than what you're using now, but ideally none, so that your B12 that we're giving you is working, so that we can get your functioning back up to speed.
Gotcha. That does make sense. So really correlating it clinically to clinical improvement of symptoms rather than solely by the laboratory value that we are following. Um, on that note, though, if some people are having more permanent deficits, how would you suggest someone approach addressing the new baseline? Because if we're looking for clinical improvements with B12 supplementation, and this possibly could have more of a permanent deficit, how would you suggest approaching following those symptoms?
It's a good question. I would sort of say at about 3 months of aggressive supplementation, maybe 3 to 6, if the person really has ceased use and getting aggressive B12 supplementation, it may be that you see sort of a plateau in their level of functioning, and then it's more about encouraging not just B12 supplementation, but functional improvement. So making sure, and I mentioned it earlier, physical therapy, occupational therapy to kind of functionally address the symptoms, and ideally as soon as possible, hoping that your patient has access to that kind of care.
Agreed. Agreed. Certainly a wraparound service, as we would suggest for any substance use disorder.
Yes, and anyone who's dealing with kind of a functional disability, essentially.
Fair, fair. Good point. Good point. Michael, actually, we do have a question about the case. Was an MMA and homocysteine level taken and resulted to where you know what those numbers would be by any chance?
So we just ordered the B12 levels, but I would suspect that given that his B12 levels were undetectable, given the chemical pathway, that both methylmalonic acid as well as homocysteine would be deficient as well.
Gotcha. Okay. Thank you.
Yeah, and that's an interesting piece, because it's sort of a moot point. It didn't really change the plan of care. So it makes sense why those labs maybe weren't tested at that point because it was undetectable. I've had several cases of normal B12 and they have active paresthesias, gait instability, like they have a B12 deficiency, but it's a normal level. And so then we definitely test to prove it, but again, replete immediately.
Gotcha. Gotcha. Makes sense. Are there any other, especially because that lab may not be fully helpful in every clinical scenario, are there other types of imaging studies perhaps that could be beneficial or have classic findings in these in the use of nitric oxide?
Yeah, so there is a classic MRI finding. It's you do an MRI spine. The dorsal columns, the dorsal posterior columns will have a T2 hyperintensity, and they call it like the classic inverted V sign. It's more prominent usually in the cervical spine. But yeah, an MRI, if you have the ability to do an MRI in your practice setting, can kind of prove, for instance, sort of the dorsal column involvement that's causing the symptoms that patients may be reporting.
Gotcha. Excellent. Well, that's really helpful too. And when we're talking about the B12 replacement, someone asked for a clarification regarding IM versus oral as well. Is there a value in having intramuscular only versus allowing for oral? Would you recommend it daily versus, oral versus weekly IM?
They're different algorithms. I would recommend, and if you have them in your hospital setting and you can give them an intramuscular injection, it's going to be more effective for immediate absorption. Eventually, it's sort of like you have to sort of slide to fit your patients. And we don't always have the luxury of a patient who's actually going to come in and get an injection or be able to give themselves an injection at home. And so, you want to replete as aggressively as possible, but I could see myself being very flexible with someone and trying to give them aggressive B12 repletion orally if that's the only option. So it really depends on the patient, but the recommendation is that IM is going to be more effective.
Especially with different settings, such as this patient who came from a
Yes.
very different setting than being at home, it sounds like.
Yes, definitely.
And on that note, like I know we talked about how some kids are ordering this online. Is there any move to having more regulation with this, or whether in U.S. or overseas? Because I know sometimes things that we well regulate are not as regulated overseas, and thus ordering online is different. Is there any movement for that?
It's a really good question. And so but I did some research because I was thinking about it. So I practice in Texas, so does Dr. T, which is often sort of the Wild West of not regulating things. And it's not regulated. And my patients more recently, it used to be dispensed in these little canisters like this big that go in whipped cream dispensers, but you can buy industrial sized tanks now. And I've had people who have graduated up to that level of purchase where they go to like a kitchen supply place and buy the professional, like we're going to make massive amounts of whipped cream tanks. There is my understanding is there's online ordering that you can get direct to your house. And then there's a lot of stuff on social media. And there's actually like kind of directly advertised to the youth. There is no regulation really. The US it's legal and it's very widely available. It is cheap. It's also, because of the online ordering, fairly kind of discreetly accessible to minors. You can walk into head shops these days and they have nitrous oxide canisters. And again, they have this marketing to like youth-oriented brands that are marketed to younger kids and adults. As far as regulation in other countries, I was curious about it. Apparently, the Netherlands have a new ban on production, sale, and purchase for recreational use since January of 23. And they saw like poison exposures and like nitrous oxide associated police incidents and things like that drop, which makes sense when you're, regulating and making it harder to access it. The UK also apparently has the second most common recreational drug is nitrous oxide. And so they have been looking into escalating restrictions and they've been talking about criminalization, but I don't think they've actually done it yet. But other than that, like there's not a lot of regulation of this. It's still commonly used both as essentially a medical drug and used industrially to make whipped cream. And then it is very commonly accessible as a legal kind of recreational substance. And you can operate in the United States assuming that your patients can access it very easily.
Mm. And do you know if there's, especially if we're attempting to have complete abstinence and we're wanting to monitor for continued use without clinical sequelae of use, are there any substance use biomarkers that could pick this up like we do with the other substances?
Uh-oh, that's a good question. I don't know the answer to that. I don't think so, but maybe you can answer that, Dr. Fipps.
I do not have a direct answer for it. I'm
I
sure there's
don't,
probably some send out lab somewhere that could do
yeah,
it.
there might be. I would expect that because it's so short acting and not in your system very long, that there isn't a direct, like you can't test that there's nitrous oxide in your system because it's in and out so fast.
Hmm.
I wonder if there's a biomarker that tests the B12, because you could argue if you have, like irreversibly oxidized cobalt on your B12, but that sounds like an expensive test that's more theoretical than in practice. So my understanding is that we really don't have anything to test for to prove, which
That's
is
fair.
often the case with many of our patients who are dealing with substance use disorders.
Hmm. Indeed. Well, it looks like we're at time, so I apologize that we didn't get to all the Q&As. We had a very productive and active audience today, and so I appreciate everyone coming, and great job with the case presentation. Excellent job with the discussion and Q&A. I appreciate everyone's time, and be on the lookout next time for these webinars. This link will be placed on the ACLP website and on the different social media platforms as well. Until then, you guys have a good day.